morning. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. We have lots to talk about today, including the COVID situation. Numbers have been up, then down, then up, and now down again. We'll ask Doc Hawk about how optimistic he's feeling, but the drop was good. We're also learning about a rare genetic condition that creates thousands of polyps. That is a tough-looking colon. When left untreated, it effectively guarantees patients will get cancer. We'll hear from one of the women living with that condition and hear why it's so important to delay the need for surgery as long as possible. But first, the bitter cold. You know the weather's bad when we are getting excited for a chance of reaching 32 degrees today. We did not do that over the weekend. But then we're going to plunge back into the single digits this weekend when I was going to have gone fly fishing. Maybe not such a great idea. Since last Tuesday, our emergency department has seen at least 59 cases related to the bitterly cold weather. That includes a lot of slips and falls, a few car wrecks, some shortness of breath, exposure, and frostbite. So let's talk frostbite in today's morning rounds. Dr. Julia Slater is a burn surgeon and medical director of the Burnett Burn Center here at the University of Kansas Health System. Good morning, Dr. Slater. How are you?
Good. I'm great. Thank you for having me, Dr. Stites.
Yeah, well, it's been freezing for about 5 or 6 days now. And yes, I was one of those great folks who went out to the Chiefs game and had a great time, stayed warm. How many frostbite cases is the burn unit seeing, and how severe are they?
Yeah, so since last week, we've seen and evaluated 11 different patients with frostbite, and looking at the clinic schedule this week, we've got 5 more coming into as an outpatient setting. We were able to discharge 2 from the ER, but all the rest had to be admitted, and we're seeing some pretty severe cases and a lot of use of thrombolytics with our IR folks this weekend.
Okay, so you're going to have to tell us what all that kind of means, because you know, when you think about the word frostbite, it just seems like, oh, that's not so bad. But you may just sound that kind of is bad, being in the hospital having to use all these thrombolytics. So who's getting it? Is it only people who are unhoused? And talk to us about some of those treatments you mentioned.
So typically during the winter, the patients that we see will normally be patients that don't have access to warm shelters, so our homeless population. But when you have a really cold stretch like we did this past weekend, that changes. And it's just anyone that was out for a prolonged period of time without proper preparation for that, whether it was not intended to be out or intended to be out. And so it's not really just seeing our homeless population, which would normally be who we see. And though it doesn't sound that aggressive, frostbite is really ice crystals that form in your tissues. And those ice crystals destroy the cells and cause cell death, which is what leads to the ischemia or the loss of blood flow in your kind of extremities, we call it. So anywhere that's far away from your blood supply, your fingers, your toes, your nose, your ears, on your face are all particular sites that we commonly see frostbite.
So when you talk about my extremities becoming ice cubes, that's beginning to sound a little bit more dangerous. Why do you have to use clot-busting medication to try and improve it?
So what we have found so far is that clot-busting or thrombolytics is one of the only medications that can help decrease the risk of needing an amputation, or if a patient does need an amputation, it can actually help preserve as much tissue as possible so that we can amputate smaller parts of fingers or toes.
All right, I know we're going to talk about that more in just a moment, but our colleague Cliff Irwin, who shoots a lot of the video you see on this program, was part of a Scouts gathering in the sub-zero temps this past weekend. These are photos from the 47th Trappers Rendezvous in central Kansas. Cliff and the roughly 1,000 other campers bundled up. Lots of layers, double sleeping bags, no reports of frostbite. Hey, my son and I did great at the Chiefs game, so it can be done.
Absolutely. The first step to treating frostbite is really prevention, and that is being prepared. So having multiple layers, especially loose layers that allow some air to get between them, because that helps trap the heat and keep you warmer. Making sure that all of your extremities are covered. So face masks and the goggles that you saw in that picture, as well as gloves, often 2 pairs of socks on the feet, and most importantly is just as much as you can staying in dry garments at all times. If it gets wet, you need to get out of that.
Well, I know we're glad that Cliff and Troop 51 were able to stay safe, but how long can you stay out in those elements? And then talk to us a little bit about what wind chill really means, because some people think, oh, it's really not that cold, it's just windy.
Yeah. So as it gets colder, the amount of time that you can stay out shortens before you risk getting frostbite, similar to how as you would touch hotter and hotter water, it takes less time to get a burn. When you have wind chill, even though you don't necessarily appreciate it, it decreases the temperature around you and makes the tissue feel that temperature. And so as those temperatures go down, when you hit negative 20 degrees of wind chill, that's where you get to about 30 minutes before the development of frostbite, which is where we were on Saturday night. As you get closer to negative 40, that drops to 10 minutes. And as you get to negative 60 wind chill, that drops to 5 minutes or less until tissue starts to show damage.
That's really not very long, is it? That's pretty tough. So how does somebody know if they need first aid beyond, I'm just going to go inside and get a little warm here?
Sure. So usually the early signs are going to be that your skin is pale, that you maybe feel some tingling or some numbness to those areas. You want to go in and get warm right away and make sure you stay warm at that point. If you go in to get warm and the color is not improving, you see any blue color on any of the areas, or you start to have intense pain, those are all signs that you have more severe. Certainly, if you would warm up and start to see blisters, you need to be in an emergency room right away.
So that's really good advice about knowing when you need to go to the emergency room. And so it's really the blistering, or is it anything else that you should respond to?
The blueness is kind of the first sign that we see. So a first degree frostbite, sometimes known as frost nip, is going to really just be pale, maybe a little pink, and that resolves pretty quickly. A second degree is where we see that blueness and we start to see blistering. Third degree has blisters, and they often are really dark because they'll have some blood in them. And then fourth degree is much further than that, and those are the most severe cases that we see.
All right, well, Dr. Slater, thank you very much for coming in today, and let's keep people warm out there, and really appreciate all the great work you do and that our burn team does, especially at times like this.
Thank you so much. Have a great day.
All right, thank you. All right, turning from the cold to the colon. That was pretty cute there. The CDC recommends starting colonoscopies at age 45, but for people with a condition we're focused on today, colonoscopies could start as young as the age of 10. That's really young. It's called FAP, Familial Adenomatous Polyposis. Familial, as in family, meaning it's an inherited condition. Adenomatous, polyp, refers to a common type of polyp, which can turn into cancer if it's not removed. Helping us learn more today is Dr. A.J. Bansal, a gastroenterologist, as well as the medical director of Gastroenterology Cancers Prevention Clinic at the University of Kansas Cancer Center. Good morning, sir. How are you?
I'm great. Thank you for having me.
Well, no, it's a delight to have you. We'll also hear what living with FAP is like from Kay Secker. Thank you for being here, Kay. We'll talk with you more in just a bit. Awesome. It's good to have you. Dr. Bansal, a few polyps can be easily removed, but with FAP, the colon is practically carpeted in polyps. We saw that picture of it at the very beginning of the program. That was a tough-looking photo right there. So do we know what causes that number of polyps to develop?
Absolutely. So this, as Dr. Stites mentioned, this is an inherited disorder where you have a gene abnormality which you are born with, and with time that causes increased number of polyps. The name of the gene is called APC, and that increases the risk of these polyps forming at a very young age as age of 10.
That's really age that they start doing. I mean, 10 years old is tough. FAP is associated then with a shorter life expectancy, I'm assuming, from all the cancer these patients can develop. Is that right?
That is correct. So patients with FAP can be at increased risk of colon cancer, stomach cancer, brain cancer, skin cancer, pancreas cancer. So that's why it's very, very important to diagnose this condition in time so we can be proactive.
Now, we've talked a little before about familial polyposis. That's not the same exact thing as this, or is it? Talk to us about the difference.
So FAP is a specific form of familial polyposis. So familial polyposis is a general term referring to many conditions which can increase the number of polyps in the colon. FAP is one of them.
Okay, so it sounds like a more severe form of it, in fact, right?
Correct.
So what are the treatment options that you can do? Because that's a lot of polyps to go in and try to remove.
Absolutely. So the main treatment option is definitely surgery at the right time. We have medications. Unfortunately, many of these medications are either toxic or don't really work very well. So not a lot of options in terms of prevention yet.
Is it limited to the colon, or can it be in the small intestine and the stomach as well?
It can be mostly in the colon, but definitely around 20% of patients, it can spread to small intestine and the stomach and cause us to do more and more surgeries, which makes it tough for these patients.
Right, because you could take out the colon, but if you have to start taking out of your small intestine, your stomach, it's going to get hard to get all your calories in, right?
Exactly right. So the normal length of small intestine is approximately 18 feet. That's 3 times as tall as Dr. Stites. I'm assuming you're...
I'm about 6 foot. I used to be 6'1", but maybe not anymore.
Yeah, so 3 times as long. So each time you do surgery on the small intestine, you lose that ability to absorb food and nutrients. So if you get to approximately half, that's when you need TPN and stuff like that.
All right, well, let's talk with Kay Secker. Kay, you told us you were one of 5 siblings. 4 of you have FAP. And it all ties back to your dad, who I think died of colon cancer. You shared a couple of photos of him. How old was he when he passed away, and how old were you when that happened?
My father was diagnosed at age 42. He passed away within 2 months, and I was age 16. I had one older sister and 3 younger siblings.
That had to
Age
be really
range.
hard. Go ahead, I'm sorry.
Yeah, age range of 6 to 19.
So you were pretty young, and some of your siblings were all pretty young. How soon did you have to have a colonoscopy, and how soon did they get one?
Well, my personal story began in 1982. So following my father's death and what we learned, so all we knew was that my dad had colorectal cancer. We didn't know anything about polyposis. We didn't know the rest of us had a dire future. And so at one point, about 4 years after my father passed away, I was having symptoms that alternated between extreme, I guess we're here to talk about medicine, so extreme diarrhea and extreme constipation. So my family practitioner at the time said, we're going to do a scope on you. And what he found was my large intestine was carpeted like the picture we saw, with at a minimum hundreds of polyps. My siblings were brought in the next day to have those same colonoscopies and proctoscopes, if that's even something that's done anymore. So of the 5 of us, 4 tested positive for the familial polyposis. My journey with KU Medical Center began in 1985. My sister was working at the hospital there. I was coming down from South Dakota. I met up with a great GI doc, and he looked at me and he said, you don't have familial polyposis, you have Gardner's syndrome. And from then on, we just kept learning more and more. I eventually had, as did 4 in my family, we had subtotal colectomies. So my very first colon surgery was at the age of 21, and I had about approximately 6 inches of large intestine removed.
Okay. And just to say, Gardner syndrome is similar to FAP, or is
Correct.
FAP. It's just a common lay term for it. Is that right?
It's a term for FAP in which there's some other manifestations which are more pronounced, but generally that's just FAP.
Yeah. Okay.
And Dr. Bonzo, correct me if I'm wrong, but it seems like it was familial polyposis and then Gardner's and then FAP, and it just the umbrella became larger.
So it's a very complex question. So what happens is this: the APC gene is a long, big gene. So depending where the mutation happens in the gene, it decides the number of polyps and where you get them. So Gardner depends on where exactly the mutation is in the APC gene, and it can increase, it can be more aggressive.
Yep. So, Kay, I'm going to jump forward through time a little bit. You've had the number of
Sure.
surgeries, as I understand, and now you're left with a fairly short digestive tract. Is that right?
That is correct. I have 146.9 centimeters
And
of
just hold on for a
small
second. And
intestine.
how long is a normal digestive tract in centimeters?
So the small intestine is 600 centimeters. So
Okay.
she has 146.9, she said. So that's
Yes.
1/3.
Yeah, 1/4 thereabouts. Yeah. So not a lot of small intestine left. And how did that affect you to not have much more, to have such a little, a short one?
It affects me greatly with nutrition, hydration. I've been on TPN several times in my life for extended periods of time. I have learned to administer, from accessing my port to administering the TPN and taking care of myself at home.
Yeah, so just to say to our audience, TPN is total parenteral nutrition. It means we're delivering all your calories that you need, or at least a good portion of those calories, through an IV. And a port is a device that is under your skin that we can access. And when the needle's not in it, then the skin's covering it. But you go through your skin, you access it, and it allows us to give TPN so you can get the calories you're required. And that can work. And we hope is that at some point guts can modify a little bit, or can somehow over time evolve's not the right term, but the gut itself can adapt to the new environment and try to absorb more of those calories, Dr. Bonsall.
Exactly right. So depending on the length of the small intestine remaining and how much colon you have left, the best situation would be some colon plus majority of small intestine, but the small intestine can adapt and absorb more.
Yeah, so it's kind of a race. And so, Kay, are you able to both eat now and still do TPN? Can you just eat? How does that work for you?
I am not on TPN, so I'm able to eat, but I think the term that a lot of my specialists use is constant grazing.
Yeah.
I have a lot of dietary restrictions with low fiber, no sugar, no grease. It's very limiting, but I'm willing for it because that's what it takes to live.
It beats the alternative, and it probably beats TPN and getting hooked up all the time. So, Dr. Bonsall, is there a benefit to delaying the surgery until you need it? And is this part of the benefit, not having to battle with TPN and all these nutritional challenges?
So that's a great point. So when we talk about delaying surgery, we have to be careful with that term, because obviously we don't want to end up with colon cancer, which is spread beyond the colon. So what we really mean delaying surgery is mainly for people who are extremely young, between the ages of 10 and 25, because those are the times when you're going to school, having relationships, growing up, and any kind of surgery or nutritional problems can affect your growth, intellectual and physical, and your ability to succeed. So in those situations, we try to do the best we can to delay the surgery as long as we can.
So non-steroidal anti-inflammatory drugs, or NSAIDs, things like aspirin, ibuprofen, naproxen, Advil, Aleve, blah, 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 there's a long list. They have a role in some of this.
That's amazing. Yes,
It is amazing.
Yeah.
I thought it would help my joint pains as I got old.
These medications also block an enzyme called COX-2, which has been involved in polyposis and making polyps in the colon. So these medications can be effective in delaying surgery in some patients.
Yeah, so it can be helpful then to take it. How much can it delay it?
So I have patients in my clinic. I start seeing them at the age of 17 and a half or 17, 18, and I've been able to delay their surgeries till 21, 22, and just keep them going. For the most part, FAP is a slow-growing disease, so even though we have so many polyps, they grow slowly. So with the right medications, the right amount of colonoscopies, you can buy 3, 4, 5 years.
And so you published an article in Gastroenterology Advances, I think, and found that with a treatment with using NSAIDs compared to the placebo, you reduce the number of polyps by an average of 17% and polyp size by 16%. So good news on that front.
Correct.
But it's not at the panacea. You need a new drug, or you need some kind of genetic therapy. How far away are you?
So gene therapy is quite complex. As we know, in the past few years, gene therapy was approved for sickle cell anemia, partly because there you can go to the bone marrow and change the cells. Here, you can't go back to the embryo which we came from, so we have to find a method of delivering gene therapy to the colon, to the small intestine, and make the cells take it. So that's being tested in mice and animals, but that's still way in the future.
And is there any chance of building a way to repair the protein that's involved in the defect?
So what Dr. Stites is talking about, the replacing the protein which is missing, the APC protein, in theory it can be done, but to make sure it goes to the right cells in the colon and upper GI tract is a very hard task.
It is tough. We did it in cystic fibrosis. You could do it in familial adenomatous polyposis, or of FAP. All right, we are here to answer your questions. Send them to the links on the screen, YouTube, Facebook, Twitter, or email the Medical News Network. Let's check with COVID count with Dr. Dana Hawkinson, Hawkeye, Medical Director of Infection Prevention Control here at the Health System. Hawk, welcome back. I guess it's welcome back to me. You're back before I was, so.
It's been a while.
It has
Holidays
been a while.
And cold weather.
I
so.
know, a little cold weather out of the way now, though. We didn't get frostbite. We did good.
I know.
It makes the Royals season look a little warmer. That'll be fun. But talk to us a little bit about the COVID count.
Yeah, well, I would say we need some CRISPR for FAP.
Yeah, I was going to go to CRISPR technology.
I'm sure it's going on. There's smarter people than us.
Yeah, when we're
working
doing
on
CAR T for that disease.
Yeah.
Okay.
Well, right now, Steve, we had been in those low 30s for active inpatients for COVID. We are much better. This past week, we were at 23 active inpatients. We do still have several in the ICU, but overall, the numbers are much better. So I think that is good news for everyone.
Yeah, I love seeing the number go down to 23. That's outstanding. Mm-hmm. And let's talk. I think we got some graphs to talk about.
We do. Yeah. So this is the first one. Again, I think this is from the week prior, but what you can see over here is that green is COVID. That's going to be on the farthest left-hand side. And this is for whole health system virus admission. So green on the far left is COVID. Orange is the RSV. You can see that little orange bar there down on the far right. And then influenza, flu is blue, and that is kind of that third bar. So you can see how the last few weeks have stacked up as far as our admissions to the health system for all of those viruses. You can see the peaks and a little bit of a valley now, especially for RSV, and maybe a little bit lower for influenza as well. But we'll see what the next week brings as well. So I think overall, that is good news. I think that does signal maybe a decrease in the circulation of the virus around our community.
And just to say real quickly that, the number, it's hard to tell in the graph sometimes, but there's 17 influenza admissions, 8 RSV admissions. Yeah. And again, we don't have that many kids, so children's has a whole bunch more than that. But still, we track it relative week to week. And influenza dropped and RSV dropped, so that's a really good sign, although influenza sometimes has a later peak. Mm-hmm. COVID was still high, but at least people aren't as sick. We only had 2 ICU patients, so that's good. We'll take that.
Yeah. Yeah, absolutely. And the next graph we were going to, just talking about the circulation, we saw that our percent positives overall went down. Coupled with that, also the number of tests went down as well. So I think, again, that is signaling maybe reduced circulation. There was, a peak earlier a few weeks ago. That kind of has gone down, maybe just a little bit bump. It's hard to say if that's going to be sustained or if it's going to continue on the downtrend. I think we have a couple other graphs as well that we can show to hopefully support that. This is a really good graph. This is from the CDC. This is looking at ILI, or influenza-like illness, and the amount of people that are going to a primary care, urgent care, or emergency department for influenza-like illness to get evaluated. You can see that there was that peak over there on the left in the 2022-2023 season. It looked to be a little bit earlier, but now we are in the 2023-2024 season, and that's that kind of dark red peak over there. And this, the peak was the last week of 2023, and then you see that decrease, and that was the first week of 2024. Here what we're showing is that there is a trend, and we are comparing it to the previous 4 seasons of influenza-like activity as well. And I would just like to point out that really the 2023-2024, so this current season, right now really looks like it did in 2019-2020 season. So I'm hoping that is signaling now we are getting back into that more of that seasonality. We know that when the pandemic hit, that changed a lot of things, and that can be evidenced by that low green line right there, and that was the 2020 to 2021 season. So that would have been, October of 2020 into April of 2021, essentially. And you can see there was a lot of masking. There were a lot of local community mandates that were going on, restrictions on people going inside. So that really cut down on the overall illnesses circulating around the community and people having to go to the physician to get evaluated. But now I think we are getting into more of our quote-unquote normal seasonality of these viruses, and that is including COVID at this point, or SARS-CoV-2, but I would still expect SARS-CoV-2 to be in higher circulation even in those warmer months compared to, say, influenza and those other cough and cold viruses as well.
I've heard it a couple of times. So see, now really COVID's not as bad as the flu, and that's not accurate. If you look at those admissions, we still have twice as many COVID admissions as we have influenza admissions, and people are still sick, and we have more folks in the ICU from COVID than from influenza. So the idea that COVID is not as bad as influenza is false.
Correct.
The idea that it's nothing but just another seasonal virus is also false. Now, it's clearly not as bad as it was in the beginning, but a lot of that has to do with people getting it a lot and vaccination and improved therapy.
Yeah, and I would say, unfortunately, the people that did pass away during the height of that, the beginning and the height of the pandemic as well. So again, as you have said and we have said, COVID really is more of a significant disease for those at risk: age, heart disease, lung disease, diabetes, immunosuppression. Those things are going to increase your risk of hospitalization, but it still affects people on a daily basis. Even otherwise healthy people can still be hit pretty hard with this, with symptoms and persistent symptoms. We know long COVID is still there as well, although hopefully in less magnitude as it was early on in the pandemic. And again, that's because of vaccination and infection and reinfection, building up that immune response.
Yeah, we know that long COVID is a bad deal,
Yeah.
and it's a stronger feature of COVID than it is in influenza. You can get long influenza, you can get the long viral, but COVID is clearly worse. And we just hope that this waning is what we see ongoing, and that another variant doesn't crop up to cause more difficulty.
Yeah.
But it is a welcome season we're having so far around a lot of this, so that's been good news. Okay, we know many of you have questions. Let's head to Studio B with Alexis. Alexis, how are you?
I'm doing well, and I'm glad you have your vest on in case you have to go outside today, Dr.
You know,
Stites.
I am vested, I am invested and ready.
It's vest season for Dr. Stites.
Absolutely.
Ruth Ellen has a comment. She wants you to know that the graphs are very interesting that we use to illustrate things during the program. So a thank you from Ruth Ellen. And we have a question from Omar, who submitted this to us on YouTube. Omar wants to know, this is a good question, what do you mean by evidence-based medicine, and how is it different from 20 to 30 years ago?
Okay, it's a great question. So when we say evidence-based medicine, what it is, it means that we are looking at research and scientific data that's been shown in patients to demonstrate a certain way of prescribing medications or treating patients. When we follow those guidelines, we call that, okay, we're doing it with evidence-based medicine. The advantage over 20 or 30 years ago is there's a lot more evidence. Research has come a long way. There's a lot more tools at our trade, and we are much better at it because we've got a lot more information at our disposal to guide our therapies. Dr. Bonsall, any other thoughts? Because I know the Cancer Center is all about evidence-based medicine.
Absolutely, and completely agree. And one other thing which has happened is that we have much better study designs, and we have many, many good statistical methods to make sure that the result we find from a trial is indeed true, so we can make sure we don't expose patients to unnecessary medications.
And I'm just going to say, just to toot our horns a little bit, first of all, academic medical centers lead the way in that, and second of all, the United States leads its way in that. And clearly, some of the best research in the world comes out of this country. We may have all these other fights, but we clearly lead the way around evidence-based medicine. And Hawkeye, you guys use this daily in the infectious disease world.
Yeah, I mean, we rely on it a lot. I think we all really look to, I would say, especially our cardiology colleagues who have always led the way in that. But certainly,
don't give them that credit.
I know, I have to though. They always have their algorithms and their flow charts of giving the beta blocker and giving. So, we got to give credit where
I would have
credit's
said
due.
cancer. I would have said cystic fibrosis.
But it really is an overreaching theme in medicine and what we practice every day. And we always look for that evidence. And it's well done evidence as well. And it's asking the right question so that you can get the right answer to that question, so you know what experiments to perform. We know, especially during the pandemic, there was a lot of publications coming out. There was a lot of research done, and they would find results that really didn't have anything to do with the question asked. So it's hard to draw comparisons, and so it is very specific. But it helps us gain the knowledge to be better equipped to find out what is wrong with you and to treat that most effectively to really help you get home and get better as well. And just as Dr. Stites, just as you said, it has come a long way in the last 20 years for sure. We know that we can get those correct questions. We know that we can hopefully come to those answers, but that does help because in the long run, we continue to build on that success and that information to continue to find better and better treatments as well.
Yeah, instead of having N of 1, which we would have a lot of historically, which meant each physician had, well, this is my personal experience, this is what I'm going to do. And that comes with a lot of biases and a lot of challenges. When we are blinded, we don't know what the data actually, we don't know who got the drug, who didn't get the drug, then we actually have to look at the results. What's coming in the future, we'll go from evidence-based medicine to precision-based medicine, which is also a form of evidence-based, but then we're going to be looking at your genetic profile and your specific situation and what's right for you. That is going to be completely transformative in medicine. Alexis.
Stu has a question. How rare is FAP?
Oh, it's pretty rare.
It's quite rare. So if you look at all patients who present with colon cancer to an institution, 1 in 100 of those patients will have FAP.
So 1 in 100 just having colon cancer, but that means in the general population, the defect that causes FAP is about 1 in
100,000.
Yeah, so not very often. Yeah, very rare.
So I have a question for Kay or the doctors. Kay mentioned she has 5 siblings, only 1 didn't get FAP. Is there a way to study the one that didn't get it to figure out how they were able, what in their system is different?
Dr. Rose, I want to have you answer that, and then Kay, I'm going to talk with you a little bit about this question because there's an important side to that question.
Absolutely. So that's obviously a great question. So unfortunately, that's just chance. So as we know, every gene in the human cell has 2 copies. We get 1 copy from our father and the other copy from our mother. So the gene randomly goes into the embryo. So unfortunately, this is happening at the time of conception. So we can't really fix that. Although there is something called pre-implantation diagnosis, where couples who know they have a history of FAP and they want to start families, they can use pre-implantation diagnosis to make sure the embryo does not have the bad gene of FAP.
So, Kate, in your family with your siblings, does the person without FAP feel guilt? I mean, how is that? Because I know in CF, sometimes the siblings who don't have it feel bad for the siblings that do.
Well, yes, there is a survivor's guilt or a guilt of not having what everybody else has, but she got her share too. She ended up with breast cancer, non-BRCA breast cancer. She adopted a child who had leukemia at age 3.
Oh my God.
So she didn't get by scot-free. Of the 4 of us that were diagnosed with FAP, 1 of the 3 of us has a different genetic mutation. And all of our genetic testing is in the hands of KU right now. I need to get back on track with that, but so there's, did this other brother, does he really have FAP? Well, he's had polyps, so you can't rule that out completely, or thus far it hasn't been ruled out. So we just have a lot more testing to do.
Wow, that's a story of some tough genes, though.
Yeah.
That's tough.
Boy, you never know what someone's going through. Kay, our hearts go out to you and your family. That's a lot. That's tough.
That is a lot.
Well, Jack has a question about Kay's diet. Kay, you mentioned you have some restrictions, one of them being you don't eat greasy food anymore. Why not greasy food? What does that do that's so bad?
Well, the biggest no-no from the get-go was fiber.
Okay.
Carrots are killers. Grape skins are killers. Cause bowel obstructions and all of this. But this is the gift that keeps on giving, and so the latest complication to this is severe acute pancreatitis. So now I'm on the fence with my physicians. So do I have another risky surgery to take out my gallbladder, or is some less aggressive, something like an ERCP with Dr. Bonzo, am I saying this right? Sphincterotomy?
Yes.
There's always something, but you just get used to it and you go with it. And
I think you have a degree in gastroenterology and genetics, and I apologize that you've had to live through that, but you have a degree in it. Yeah.
I've learned a lot.
Yes, well, that's important because the patients who learn are the ones who can help take care of themselves the best. So, Alexis.
I am a very ambitious patient, I guess you might say.
That's the best.
Motivated
I have to say
patient.
that Kay is an amazing patient. I have known her for a while, and the way she absorbs information, the way she follows through, her desire to keep going and stay strong is just an inspiration.
Well, and you've had to modify your life so much in order to survive, and that is a tribute to you and your spirit. So, team, thank you all so much for sharing and spreading the word about FAP and being a part of this program. I want to turn and get final thoughts. And Kay, I want to begin with you. You've given powerful testimony to what it means to be a patient today. Final thoughts.
Final thoughts. Listen to your body. Watch for trends. I had the heads up after my dad passed away and after I was diagnosed with the polyps. I knew to watch for it. And all those years later, I ended up with stage 3 colorectal cancer and a permanent ileostomy and all of those things. So yes, listen to your body. The body does the talking.
Yeah, I think that's great advice. Sometimes I don't always want to hear what my body has to say, like slow down, but I got to listen to it because you're right. The body does the talking. That's perfectly said. Well done. AJ, Dr. Benson.
So I think I have two final thoughts. One is that a lot of stuff is happening in the near future with a lot of hope for patients with FAP. One is vaccines. So right now, I'm leading a trial of vaccines in a syndrome called Lynch syndrome, and we have reason to believe that the same set of vaccines could be useful for patients with FAP. So, Kay, for you and your family and younger grandkids, there's a lot of hope in the future. The second comment I have is that I believe there should be healthcare legislation to protect patients like FAP from the costs of healthcare, partly because what happens is with a condition like this, it affects the economic situation of a family because many of the grandparents and parents die at a young age of 40, 45, and most of us accumulate wealth after 40s and 50s. So I feel that there should be some sort of protection or legislation to protect these patients against the costs of healthcare.
Dr. Bonzo, you and I should have a long conversation of agreement about that because when you deal with patients with chronic disease, you can see how devastating it can be to people financially, let alone medically and health-wise.
Yeah.
Hawk.
Again, a great conversation, and I think it also we continue to need to endorse screening and getting those screening done, especially those screening colonoscopies, mammographies, anything. It is hard to keep up with it. It is important to speak with your medical team, your physician, try to get access to one to help with that screening to find those diseases earlier to improve your rate of survival. In addition, we know that vaccination still works and help reduce your chance of hospitalization, severe disease from these respiratory viruses right now. There still is time to get vaccinated if you haven't yet. Hopefully we've seen a peak in activity of RSV, influenza, and COVID, but we always know that we can have second peaks and third peaks throughout the rest of the cold months. So please go get vaccinated and always have a plan if you should have symptoms as well.
Well said. All right. So, Case Ecker, thank you so much for being on this program. You did a great job. I listened to that word, the way you said it. Listen to your body. It does the talking. I'm going to remember that. I may steal it. To Hawkeye and, of course, Dr. Bonsall, thank you all very much. And, you know, today we've talked again about that intersection of faith, hope, and science, the ability of science to deliver evidence-based medicine to try and help us make sure we take care of patients who have severe chronic diseases and to whom's body is saying to them, man, help make me get better. Thanks to all of you for listening to our program. We'll be back next week.
Coming up Friday on the Morning Medical Update. Weight loss surgery is a goal, but not a finish line. For one woman, the real life-changing moments came years after losing 150 pounds. I'm Jessica Lovell on the next Morning Medical Update. From skin removal to breast reconstruction, the importance of reclaiming the body post-weight loss. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.